Welcome to the Dr. Bergson's Best Health radio show. We have a really incredible show today. We are going to be talking with an expert on hormones, and this is a physician who wrote a book called How Your Doctor is Slowly Killing You, A Woman's Health Survival Guide, and that's because she went into full menopause at 35 years old, and she had to hack her health out of the mountainside. So this show is going to be a new viewpoint from another set of eyes on hormones. Now, hormones in the pandemic have really been shown to be the powerful physiologic signaling molecules they are. It's not taught in med school that they're foundational, but it certainly has been showing up with COVID. We know that females get COVID more, but they die from COVID less because estrogens are immune modulatory. Yes, we started learning in December 13th of 2019 when there was a 19-year reanalysis of the Women's Health Initiative, which didn't make headline news, that estrogen, if given to women even for a few years, ended up protecting their breasts against getting breast cancer. They had 29% less cases of breast cancer if they were on estrogen just for a few years. And if they got breast cancer after having been on estrogen for a short period of time, they had a reduced fatality rate by 44%. Nothing else in pharmaceutical history has ever been shown to do that. So estrogens really are immune modulatory. That's one of the reasons that women fare better with COVID than men do. In fact, some of the new studies looking at how to keep men from being intubated and dying from COVID are taking a look at giving men estrogen. Mount Sinai has a study going on right now where they're giving that's intramuscular injections of progesterone, 100 milligrams twice a day to men, because progesterone and estrogen help the immune system fight off viruses, especially in the lungs. And when you get a severe virus, you get massive leaky gut, and estrogens help protect against that, and so does progesterone. So, boy, we're learning so much. Just to give you a little hint of what's going on, if you go to PubMed and put in estrogen and COVID, you see titles like, Could Estrogen Protect Women from COVID-19? Another one, Estradiol, Progesterone Immune Modulation and COVID-19 Outcomes, the role of androgens in COVID-19. The literature's kind of going back and forth, but studies are now looking at giving anti-androgens because male hormones are thought to do the opposite, although there's one study that says something different. You know, why would nature make the very hormones that drive humanity not be anything but helpful? Here's another title, Sex Hormones and Novel Coronavirus Infectious Diseases, Prevention and Therapy of Coronavirus, giving exogenous, that means estrogen not that your body makes but from outside of your body, treatment for both male and female patients. I'm telling you that estrogen is in the news, and we have an author, a physician, and a patient herself who is all about estrogen. And let me tell you a little bit about her. And by the way, she's kind enough to let us be interviewing her. She thought she would be back at her professional studio, but she's in her new home that does not yet have a professional studio. So we might have a little bit of hammering as that home is being made ready for this hormone diva soon. So there might be a little bit of that. On the show today, I'm excited to have Dr. Angela DeRosa. She's an osteopathic physician specializing in female health. And as I said before, she's written this book, and I want to do a deep dive into what is going on in this book. I love the title, How Your Doctor is Slowly Killing You. And there's a picture on the cover of the book when I went to Amazon of doctors or practitioners' hands with rubber gloves just filled with pharmaceutical medications. In 2018, she launched something very interesting, and we really need this in medicine today. She launched the Hormonal Health Institute, which is an executive instruction program for medical professionals. It's a hormone healthcare consultancy designed to instruct medical providers, because let me tell you, after the Women's Health Initiative first came out in July 2002, saying that hormones did everything that we thought they prevented, and many doctors in the United States threw hormones out the window. We have been living in a hormone wasteland for almost 19 years. So a lot of docs weren't trained in med school anymore how to dispense, to treat and individualize and take care of women's hormones. So it's wonderful when we have someone on the show that has actually launched a program for practitioners to provide them with training on how to give bioidentical hormones. So we're going to talk about the bioidentical hormone fight that is going on with the FDA. So welcome to the show, Dr. DeRosa. I'm going to call you, if I can, Angela, Dr. Angela, is that okay?
Please, or my patients like to refer to me as Dr. Hot Flash, which I have taken on very endearingly.
Well, you have red hair and an orange shawl on, so that's kind of...
There are days, that's exactly how I feel, like the heat miser from that Christmas show.
Well, she's in Arizona right now. How hot is it there?
Actually, not too bad today. It's in the upper 90s.
Upper 90s. Well, I love heat. I really love heat. And I was raised between Chicago and Scottsdale. So you're in one of my very favorite places in the world. So tell us a little bit about why you gave your book that name and what you have in that book. What's the top 3 bullet points that you want women to know about protecting themselves against the medical system and their hormones?
So it was a long thought and process about coming out with a title that I knew would be inflammatory. And the book wasn't written for medical professionals. It was really written for the everyday woman who was really striving for information about hormones, because they certainly weren't going to get it from a lot of our medical professionals, as you've alluded to. And it was meant to be kind of sensational, to grab your attention. And I always have to explain myself when I get to talk to other clinicians who may not have a sense of humor about it, let's just say. But to suggest that it's not that doctors are intentionally hurting people. I think the majority, 99.9% of physicians out there are really well-meaning and want to do right by their patients. Unfortunately, as you've also alluded to, that most of us, once the Women's Health Initiative came out, were fed a whole lion's share of bogus data that was never really managed properly. And people just stopped looking at hormones as treatments, and they just decided to think that they were dangerous, and that was it. So unfortunately, they bought the conventional wisdom and dogma, but they didn't. It makes me crazy though when physicians say, oh, there's no data. Well, there's plenty of data. You've just chosen not to look at it and evaluate it and scrutinize it. And
okay, so don't backpedal from your title, because you are saying that they aren't.
So they're not intentionally doing that, but they are unintentionally doing that, because as you and I both know, when you start to look at root cause symptoms, so for instance, if a patient comes in with hot flashes, or they're depressed, or they have muscle acheness, first thing, they're either going to be labeled crazy, fibromyalgic, or every other condition that ends up putting them on either psych meds, sleep meds, cholesterol meds, you name it, beta blockers, and all these different things to control symptoms, when the root cause of that is really the hormonal deficiencies. And unfortunately, women end up on 5, 6, 7, 10 medications by the time we're done over a period of years, not improving, not getting better. But if someone would just address the root cause, which was either a thyroid imbalance, testosterone deficiency, estrogen deficiency, progesterone imbalances, adrenal issues, all those root causes, they would never need those medications in the first place. So unfortunately, as an internal medicine physician, I was watching patients I was doling out medication after medication after medication, and watching people do a slow march to death and hoping they'd be compliant with their meds, but nobody was getting better and I wasn't doing anything of value. But when I really learned the role of hormones, that not only do they help our quality of life, but they also prevent chronic illness, I knew that that was the path of medicine I wanted to approach. And so the book was really written to say, you know what, unfortunately, medicine's doing some things that are slowly killing women, and you need to be aware of it, and giving them the survival tools to be able to ask the right questions to get the right care was really the whole purpose of the book. So when you ask me the top things, is number one is to educate yourself really about what are the true information about the hormones, testosterone, thyroid, estradiol, progesterone. Number two, the book is really designed to be also, as I say, a survival guide. It gives them checklists of the right questions to ask, what to look for in a clinician, where to find the clinicians that can help you, and then what to know that you're getting fed a line of bullshit, from the medical society. And to number three, first and foremost, is to trust your instincts. And because women know their bodies better than anybody else. And if they feel in their gut that they're not getting the right care, keep searching, because they're probably not.
Okay, very well said. And we're going to do some deep dives into that. But I'm very struck by your personal story that you went into premature ovarian failure, I guess. I don't know. You went into menopause at 35. Can you talk about that in your own journey?
Of course. And that's really, as I think when certain things are crises or traumas that happen to us in our lives really lead to greater missions and good. And for me, I honestly believe that was my mission. When I was in medical school and residency, I started experiencing a whole host of symptoms, from hot flashes, night sweats, depression, anxiety, new onset panic attacks, weight gain, fatigue. And everybody kept assigning it to the fact that I was a medical student resident, it must be just stress. And what was also more alarming is, though, during this period of time, I also started having exercise-induced syncope. And it turned out that
you have to explain that for some people that are listening. Okay.
So basically, when I would get on a treadmill, or all of a sudden I would get fatigue and I would get really lightheaded and I would pass out. And that was a highly unusual symptom for someone who was in their 20s and otherwise healthy and young, very young. And I ended up seeing cardiologists, endocrinologists, all these ologists. I was put on beta blockers because they saw I was having runs of PVCs, which are a regular kind of arrhythmia in the heart. And in hindsight, it was really estrogen deficiency, which was causing that. And
so in your 20s, you were starting to have insufficient estrogen.
Exactly. So I was in peri-menopause during my training. And it wasn't until looking back when I finally realized I went through menopause at 35. When I was in menopause, or when I was going through peri-menopause, is when I was going through my training. But instead of someone saying, oh, yeah, I think you're in peri-menopause, or look at your hormones or any of those things, what I was getting was medications. They told me I was crazy. So I was put on antidepressants. I was on sleep meds, anti-anxiety meds. I was put on a beta blocker to control my heart, cholesterol meds, all these different medications to try to help me. And I needed zero of them. I needed hormones. And I became so incensed by, here I am, a medical professional.
How did you figure this out? If you're not being taught this in school and your doctors aren't doing it, where did you connect the dots?
I was researching and trying to find the right answers. And it was actually a mentor of mine, Dr. Elizabeth Belite, who's actually in Tucson. And although I don't
spell her last name?
Belite, Elizabeth Belite. And I don't agree with all of her tenets now. I've kind of outgrown some of her thoughts, but she's been in this space for 20, 30, 40 years, and she saved my life and put me in the right direction and gave me the education to explain to me what was happening to me and had happened to me. So I consider her one of my true mentors. And then from that point on, it was, you go, girl. I want to fight the fight, and don't let the white man bring us down. I'm on a mission because I changed my whole course. I wanted to be a cardiologist. I wanted to do all these things. I said, nope, I'm going into women's health. I did a fellowship in women's health. And then I dedicated my whole career, the last 25 years, to understanding the role of hormones, and not only us feeling good, but in preventing chronic illness, which you as well know is estrogen helps prevent blood pressure issues. Testosterone helps insulin resistance. Thyroid helps cholesterol. I mean, you can just see all the connections. And if you don't treat those, people are going to continue to get sick and nobody gets better. And they just keep putting on more meds and meds and meds and meds. And that seems to be medicine's way of dealing with things.
It's really extraordinary that the critical physiologic role, hormones, are foundational. One of the reasons we eat a good diet is so hormones, when they dock into their receptor, will be able to nestle on into the receptor, shimmy in space, and give messages to the gene. Yes. And if there isn't magnesium, B6, iodine, zinc, all of these nutrients, vitamin A, we eat well so that our hormones work. But doctors aren't taught that in med school.
No, and the importance of nutrition or decreasing inflammation in the body is so vitally important to allow our hormones and everything else to function.
I've got a girlfriend who graduated first in her medical class. A lot of the docs in town know her. She's as sweet as she could be. She's very, very smart. She's an internist. And she said she's never run an estrogen level, never run an estradiol level on a woman or testosterone level on a man in her life. And she couldn't understand why she would do it or what she would do with it. And I can't understand that she's practiced medicine without running it. So we're like speaking two different languages. She might as well be speaking pygmy. Right. And I'm speaking Italian, and we're not meeting in the middle. And I don't understand, kind of like Rodney Dangerfield, why don't hormones get no respect? I don't get it.
Well, and I try to use this analogy whenever I get into arguments with other physicians. They're like, we shouldn't be treating women with hormones, and it's Mother Nature and it's nature's way. You're supposed to go through menopause. So I say to them, okay, so let's think about this for a second. So TSH, as you know, thyroid stimulating hormone, that is I call that when I'm describing it to my patients, it's a whip. It's a hormone that goes and whips the thyroid into making more thyroid when it's not functioning properly. So the higher that whip goes up, the more upset the brain's getting that the thyroid's not working. So if, for instance, normal is around 1, if a TSH is around 100, the patient's probably close to comatose. So, and then everything in between. So the higher that number goes up, the more malfunctioning that the thyroid's going. So really that TSH is the brain telling us it's really, really pissed off at the thyroid, and thyroid better go back to work. And until the day we die, the brain is going to continue to go beat that thyroid to get it to work if it's not. Well, why on earth? FSH, follicle stimulating hormone, which is the same whip, but it's the whip that goes and beats the ovary. So until the day we die, the FSH will go up and up and up and up and up after menopause, because the brain wants our ovary to make estrogen and testosterone and all those hormones. But once we go through menopause, and it's purposely done because we're not supposed to have babies in our 50s, 60s, and 70s. That would be absurd biologically. But unfortunately, the unintended consequence is the ovary, which could help us get pregnant, was also the organ that's making all these wonderful hormones. Well, the brain senses that deficiency and it kicks out more and more FSH and pumps it out, pumps it out, and pumps it out, just like it did TSH when it's upset. And if for some reason menopause was normal and the brain didn't require estrogen in the body, the brain would stop producing FSH, the whip, but it still does till the day we die. So you can't tell me that TSH is important to treat, but FSH isn't with estrogen. So biologically, you can't have the same thing occurring.
So I've got a question. When you put a woman on hormone replacement, do you track her FSH, and do you want her to go closer and further lower down? Do you want it to go like menopause is above 20, 25? Yeah. Do you want it to go at the lower? Where do you want the FSH to go when a woman is on the ideal hormone?
So you brought up the number one thing I like to teach providers is that a lot of providers follow just estradiol, which is helpful, but actually by itself, it's useless because you need FSH to really tell me what's happening at the brain level. And let me give you an example. So if a woman comes in and her FSH is 5, which is normal, 5 to 10 is really optimal, and her estrogen is 5, that tells me that the brain is sensing normal levels, but the estradiol is very low. So what would potentially be that scenario? Well, it's actually the menstrual cycle where you have estrogens really low and FSH normal. But if you have another patient who comes in with estrogen at 5, which is really, really low, but an FSH of 100, which is way too high, that is indicative of menopause. So those two are very valuable together. So then let's say that patient comes in with that really high FSH in menopause. When I start treating her, I look at the estradiol levels, but I monitor the FSH because when it normalizes, I know I nailed it for that patient because I could have an estradiol, say, of 100 in 3 different women, but each brain would sense is that adequate or not. And the only way to know is by looking at what the brain is telling me, which is
that you're the one other doc that I know that does that. So what is your sweet spot when you say, yes, I've got this woman's estrogen at the right level? What should her FSH be at?
It's optimal for most patients, 5 to 10, but at the very least under
even
20.
Though she's 60 or 70.
Yeah. Okay. Yeah, because the way I'm looking at it is we're not trying to give women estrogen just to get rid of their hot flashes. I'm trying to normalize her physiology and normalize her body function and optimize it. So when the brain tells me the body's happy, which when you look at the studies, when FSH is below 20, you remodel bone properly. Your endothelium is going to stay healthy. And
that's the lining, the inside lining of your blood vessels. And your heart health is based on your endothelial health.
So you need to drive at least below 20 in most patients, because some women don't tolerate that, but 99% of the patients do, under 20, but closer to 5 to 10. So
this is important. If you're going to be on hormone replacement, you want to work with a practitioner who's going to be okay with monitoring your FSH and continuing to tweak your hormones till you get to the sweet spot, that FSH sweet spot. That would be a good name of a little ebook.
I like it. It's kind of like the G spot. They're both useful.
So are there any other hints that you have when you know that you're tweaking your hormones just right for Goldilocks, just right for a patient?
Well, obviously, the numbers are important to follow. The brain FSH to me is my real gold standard. But again, they're numbers. We need to look at and talk to our patients. So finding out how they're doing clinically, because I could drive everything into perfect numerical order. But if she's sitting there having significant breast tenderness, she's swelling and gaining weight, then I know I probably have a little bit of estrogen excess in that woman. She's telling me that she's not tolerating it, at least in particular in the beginning when you start hormones, because women's receptors aren't reset and everything. And it takes a while for the body to readapt. In particular, women have gone a long time since menopause.
Right.
So it's important to listen to the patients in conjunction with the numbers.
I write about it in Safe Hormones, Smart Women. I've got a book out by that name, and I talk about how if you've been away from menopause for 10 years, your receptors, and many of your hormones deliver messages again to a receptor. And I worked with the two scientists Elwood Jensen discovered the receptor, so I worked with him at Tulane, and then Yanaki Gustafsson discovered this with Ken Korak, discovered the second receptor, and they would say hormones are all about receptor functionality. They're about receptor functionality, but which is about the nutrients, and then they have to be available, so there can't be pollutants or too much cortisol or this or that. But that's not how it's taught.
No.
And most gynecologists, one, don't believe in hormones these days. They kind of like their religion. Yeah. And the other one is it doesn't matter whether it's saliva or urine or blood, they just run a level and they're not looking at this larger picture or the FSH or these other nuances that help get you really kind of to turn back the clock and be younger, longer. That's the whole point. And need less meds. Right.
And you're absolutely, and then when I explain the receptors to patients, I always say they're like a little flower bed that they die over time if you don't take care of them, but then you have to put the nutrients back in the soil, the hormones, all those things with the receptors regrow, and then they function and they're beautiful. So.
But you know what's really cool? There's another kind of receptor that's on membranes, the transmembranous receptor. That's the third estrogen receptor that's been discovered, the GPR receptor. And that is all about sensation in the gut, why women have more irritable bowel syndrome. So there's a variety of receptors and when I worked at Tulane, we now know about 12 estrogen receptors that we don't even know the functions yet of those other receptors. So it's an unfolding fairy tale. We don't know the ending.
Another thing that too, just to kind of bring up the thought is, and again, we're focusing a lot on estrogen, but testosterone in women is probably it's the most abundant reproductive hormone in women, and when balanced properly in conjunction with estrogen is highly vital. And those androgen receptors are really, really important in all of the function of the organ systems too.
There's no appreciation for that in med school. Really not.
No. It's actually, if you were to put a gun to my head and say, pick a hormone, I would probably choose testosterone for the role. I mean, estrogen is such a vital hormone, but testosterone, we think about it all in sexuality, which is really important in making sure we maintain intimacy and sexuality and function. But it's really, to me, a bonus kicker. When I look at testosterone's role, it's really about, it's Mother Nature's serotonin. So it keeps our mood and cognition and keeps the anxiety at bay and makes us cope better. But the primary number one role, at least from an internal medicine standpoint, is it's an insulin and glucose modulator. So when you lose your testosterone, you develop more insulin resistance, because if you think about it, biologically, men were always set up to lose weight better than us because they have more testosterone, which moves glucose into the muscle to burn clean, and they have more muscle. So when we lose that testosterone, the glucose sits in that bloodstream and it has to go somewhere. So what ends up happening is the body pumps out tons of insulin out of the pancreas, which then loves to store it in our fat right in the midsection. So, and then what happens is you develop insulin resistance because the pancreas burns out. And then all it does is proceed to diabetes. And what do? We put people on more meds, and we tell them, work out more, eat better, here's your metformin. And nobody gets better. And then they're on, soon, a few years later, they're on insulin or Lantus and all these other things. When if you just gave them testosterone, I've watched patient after patient after patient, thousands of them. They come in insulin resistant, like in their women's in their 40s and their 50s. You put them on testosterone, it corrects within 1 month. And it's astounding.
And women are always fearful of breast cancer. Testosterone is breast cancer is growth out of control.
Yeah.
Testosterone is a growth controller at the breast. It's anti-proliferative at the breast. There's a lot of literature now giving testosterone to women right after they finish their breast cancer treatment, and then helping them have a better course of that disease. And
Dr. Rebecca Glazier has fantastic data on the role of testosterone in breast cancer.
I have a little ebook on that at drlindseybergson.com. I put together an ebook on the role of testosterone in breast cancer for you to hand to your oncologist with all of the citations. It's not really written for the regular person. It's written for you to be able to hand over to your oncologist. So, because I had breast cancer 30 years ago, and I've been on hormones now for 25 years, and everybody was telling me I shouldn't, and I'm really glad that I did, or I wouldn't be who I am at this stage. So I really like to work a lot adjunctively with breast cancer patients, and I wanted to help them get access to that important hormone. I've got a question for you. Why do you think with polycystic ovarian syndrome, one of the potential presenting symptoms is elevated testosterone?
And again, I think it comes down to too little is not good and too much is not good. And when the system's out of balance, because I find most PCOS patients don't make enough estrogen, they make way too much androgen, but it's also more about the androgen receptor kind of gone awry, the inositol imbalance. So it's a complex disease state, but it's really with those androgens, not only testosterone, but DHEAS and all the adrenal testosterones as well, that are just overproducing a hyperandrogen state, which is leading to insulin resistance. But in women who have normal receptor activity, normal biological function, and appropriate physiologic testosterone, they do well by it. So I think it's a scenario where too much is not good.
Do you think that PCOS is kind of like menopause in younger women and something to do with endocrine disruptor exposure in the womb?
Oh, I'm certain of it. And I think PCOS is highly under-recognized for various reasons. It's probably, they say, well, maybe 10% of women, but I would suggest it's probably closer to 30% of young women.
Wow.
But what's interesting is that women end up self-treating and not knowing until they go off of their birth control pill. So in other words, how do you treat PCOS? Well, you have to shut down the organ that's over-secreting the androgens, which is the ovary. So I'm not a big fan of birth control pills in normal balanced women, which I can go through in a minute. But in PCOS, you have to shut the ovary down.
Would progesterone do that? Or why does it have to be birth control pills with progestins? Why do only progestins?
No matter however, you can be progestins, it could be birth control pills. As long as you shut the ovary down from functioning, it won't over-secrete hormones. So but a lot of young women in their teens and early 20s are going on birth control for contraception, and they may not even know they have PCOS until they go off their pills in their 30s trying to get pregnant, and then all of a sudden it presents itself.
But it's interesting because it might be due to exposure to endocrine disrupting pollutants in the womb that your mom was exposed to. But at the same time, birth control pills, when I worked at Tulane, we would use, so we were in the laboratory, the scientists there were studying chemicals that were endocrine disrupting. They were damaging to our hormones, which is why younger and younger people now have more and more hormone issues like older people used to have. And we would use the estrogen in birth control pill, ethinyl estradiol. We would use that as a control because it was a set endocrine disruptor. And then you get the progestin. So it's so obvious to me that there are many benefits sometimes therapeutically, but birth control pills are in of themselves endocrine disruptors.
Yes. And I, as I mentioned, I'm not a huge fan of birth control pills. Not that I think we should use them if we are, that's the only other choice. And let me explain why. So when we go on birth control pills, by the sheer role of how they work, they shut the ovary down from functioning. So that low level of estrogen and progestin is in your bloodstream, and that sends the signal to the brain, and the brain goes, well, I don't need to do anything to make follicles or nothing. So it just stops working. Well, unfortunately, when you stop the ovary from working, you stop its natural production of estrogen, progesterone, and testosterone. Well, the birth
and
control
oxytocin, pill, by the way.
But the birth control pill gives the estrogen and the progesterone back, even though in a synthetic form. But the testosterone production is not being given back. So what ends up happening is you lose all of your ovarian production of testosterone, which is 95% of it. Well, there's the other 5%, which comes from the adrenal gland. Well, unfortunately, when you swallow a pill, it kicks out a molecule called serum hormone binding globulin that goes and binds up the last 5%. So now all women on a birth control pill are leads with 100% testosterone deficiency, which will lead to low libido, anxiety, panic, depression, weight gain, insulin resistance, all of these things that we talk about that we dismiss in women. So it's not that we shouldn't use them, but we need to know that that is going to happen 100% of the time, which is a major endocrine disruption in the whole system. So I'm always trying to convince women to maybe try an IUD or various other forms that keep some of the testosterone production. But if they refuse to use anything else and contraception is a need, then at least know what's going to happen and be prepared to give back some testosterone to that patient.
The other thing they don't talk about, there's replicated, which means article after article after article, showing that oxytocin is blocked. And because of that, oxytocin is your feel good with your world hormone, and it helps you make judgment calls on your world. So there's a lot of literature that has been proven over and over again that we don't make as good judgment calls, especially in relationships, and that part of relationship angst or divorces and issues are secondary to being on birth control pills, which block these important hormones that help you have a world life viewpoint with a good antenna from your brain to your gut. And I don't know why this isn't talked about more, but at times you need a birth control pill. If you just got accepted to Harvard Med School and you don't want to get pregnant and you want to make love, you're going to need to be on a birth control pill. But it rinses out a lot of nutrients, so women should be on those nutrients. And is it possible, if you were on birth control pills, to take something like oxytocin nasal spray to offset some of that? Do you think?
Yeah,
someone who's experiencing these things?
You could certainly recommend testosterone in those patients and some oxytocin to help. And you can do the nasal spray, or there's even troches of oxytocin. There's various formats. And you're right, the research is compelling on oxytocin. But I think it's a combination of testosterone lowering the serotonin in the brain and lowering their libido. And then you couple it with the oxytocin where you don't feel right in the world. It's just, we wonder why these young women are struggling with so many mental health issues and mood disorders. It's because their hormones are jacked.
So because we have so many people in the United States, the pandemic, of course, is up the ante, but we have a lot of mental health issues, especially in our children. We have many children who talk about stress, talk about anxiety, and a lot of that is ruled by hormones, not just Prozac deficiencies. So what do you think are the good ways that parents can be more informed, or that we can make some inroads? You wrote this book, so God bless you. It's really, I have books out. It's wonderful to have written, but it's painful to write a book. And I appreciate that you went to all that trouble to do it and to be on open forum dialogues like this to pass the word forward. But what can people do? Because when they go now, they hear this conversation, they go to their own docs, they often say, you're not a candidate, I don't believe in hormones, hormones will cause breast cancer. And what do we do to start changing the mode? And at the same time, the FDA has become a bit of an enemy to bioidentical hormones. So we're going to get into that next after we address this answer.
Well, I think the biggest thing is to be an advocate for your own self, and also not to accept the status quo. And if you look at the back of my book, I have checklists of questions you should be looking for and red flags that present themselves when you go talk to physicians and nurse practitioners, whoever in the space. But the biggest thing is, if you don't get the answers you're looking for, or they appear with those red flags, then you really need to find someone else who can manage your care. And the good news is there are more and more of us that are getting into either restorative, regenerative, functional, however you want to
whatever you want to say,
hormone specialists. But the army of ambassadors for hormones is building, which is what we need. And what's really driving it are the patients, because our dinosaurs of the old clinicians who are going down very hard and not easily are fighting us every step of the way. And also we have to keep in mind, as you alluded to, is there is a huge Trojan horse with the FDA and big pharma trying to use guidelines and various other things to scare physicians into not prescribing hormones, when it's all based on big pharma money that's trying to and you have a lot of organizations that are being funded by these huge mega billion-dollar corporations who are making billions and billions of dollars off the backs of women's health. And it's about time it stops, but we're fighting a big fight. And it comes about arming yourself with the proper information and pushing back, at least at the local level. And the rest of us have to keep fighting at the national level by presenting at the FDA, getting on commissions, trying to fight the organizations that are working against us. But we just need to get a point where we have such an enormous group of numbers of physicians who are willing to say, no, this is not the way we're going to practice medicine anymore, and this is the way it should. and shut down that old school thinking.
What I think I'm going to do is at the bottom of your show notes, if you go to drlindseyberkson.com and look at there'll be show notes in iTunes. This is on iTunes, Spotify, Google Play, Apple Play. It's coming in Amazon Music soon. So there's a lot of different platforms, but the show notes at my website have the most. iTunes doesn't allow you to put too much in there. So on my website, I'll have a lot more links. And Shay, I don't remember how to pronounce her last name, but she's put together a thing called We the Women, and I was part of that, and we'll have a link for that, and you could go put your testimonial with your experience of bioidentical hormones, and we're growing that testimonial page to help when we need to respond to the FDA trying to take away the legal compoundability rights of compounding pharmacists when your doctor wants to write a script for bioidentical hormones. So,
and Save My Compound is also another website that's looking for
SaveMyCompound.com. Okay, great. I'm going to want to ask you about your program and how doctors, because I teach for A4M and PCCA, so there's a lot of docs that listen to this too. So if they want to know your show, but I just wanted to make one comment that was rolling around in the back of my brain when we were talking about PCOS that I'm not sure people know about, but one of the possible components of PCOS is insufficient progesterone, or that your receptors don't listen to progesterone, called progesterone resistance. And what we're now learning is progesterone upregulates sticky proteins that help keep your gut closed when it should be closed and not open when it shouldn't be open, called leaky gut. So there's a huge amount of leaky gut with PCOS patients and a huge amount of fatty liver because everything flows out of the gut that shouldn't and bombards the liver, which is the next organ to be hit right after the digestive tract. So just keep in mind, I think that all women with PCOS need to take a look at progesterone, need to take a look at the zonulin, which is a marker for leaky gut, and need to get their liver evaluated. And I teach fatty liver at A4M in the gastroenterology module, and we've been discovering now that a lot of hepatic ultrasounds, you can get your liver ultrasound to find out if you've got fat, because if you have too much fat in your liver, you can't lose weight. No matter what you do, you say, I can only lose 25 pounds by cutting off this arm. But we're discovering that ultrasounds of the liver don't always pick up fat or fibrosis, which is scarring kind of tissue. So there's a new form of evaluation or imaging of the liver called the Fibro Scan. Have you been hearing about the Fibro Scan?
Honestly, I have not.
It's
I'm
really
fascinating to learn more.
It's liver electrography. And it is state of the art. So I'll have somebody who had fatty liver and they go on a protocol and then they get an ultrasound and it's all clear. Then they go get a Fibro Scan and it's not clear. The ultrasound didn't pick it up. So that is a new terrain. And if women have PCOS, I just wanted to make a comment since we went that direction a little bit. You need to get your liver evaluated because there's a huge hidden epidemic of liver issues, and your liver does so many things. That's why it has the highest temperature in the body. It's a little over 103 degrees because so much is going on there, but it makes sure that your hormones work well. So you can't have healthy hormones if your liver isn't healthy. So I just wanted to make this comment. I just actually wrote Dr. Rabar. He's that iconic gastroenterologist in LA that I lectured with once, and he hated lecturing so much. He never lectured again, but we ended up making a lifelong colleagueship. And I wrote him this morning saying, do you order Fibro Scans? Do you know about that? Because I'm all onto this because I think we need a good way of looking into the liver and making sure whether it's watching your physiologic back or not. So just wanted to make that comment.
That's fascinating. I'm definitely going to research that.
Can you talk about how doctors get into your program and what your program is about? So if there's anyone listening and they think they might want to join it.
Well, thank you so much for asking about that. So it's really a passion of mine because I really needed to build the clinical foundation, but I realized that seeing patients over the last 20 years, I could only affect change one patient at a time, so very slowly. So now that I've built that clinical foundation, I knew that the best next step to build the army was really to then train other clinicians to do the kind of medicine that you and I both ascribe to. And that's when I partnered with just a mastermind in marketing and just the compounding space. Linda Williams, her and I came together, kind of like the Wonder Twin powers and activating. And I'm always the form of the animal. She's the form of water, which works out great for us. For those 80s folks who knows our kids. But anyways, we built the Hormonal Health Institute because we wanted to train physicians, but we want to do it in a manner that empowers them and educates them without handcuffs. And what I mean by that is a lot of time when you look for training, in particular with pellet therapies of hormones, that they either require you to purchase a franchise, you have to sell their supplements, or you have to give them a percentage of your revenues. There's all these different things that they latch onto, or that you have to ascribe to a dosing calculators, and it's ridiculous. So what I wanted to do is create a module where, and also I didn't seem to see a lot of practical application of this. They give you a lot of theory, but nobody holds your hand A to Z, where they give you the education, but then help you operationalize it so that you can actually start seeing patients and applying it in a practical manner. So we created 2 programs. The first one was where it's called our concierge handholding, where basically I come in and I train clinically with that clinician. It takes us about 20, 30 hours to go through all the clinical.
Do you do it in their office or do they come in your office? How does that work?
Pre-COVID, we were doing it in their office, or they come to ours, but since COVID, we've been doing a lot of that and breaking it up into smaller sessions on Zoom. And then I come into their clinic if they're doing the pellet therapies, and I do the hands-on instruction on how to do actually the procedures, help them get their practice up and running, making sure they have their consents, their templates, all of those things. So we help them with all of that. Then we realized that not everybody wanted to afford that level of kind of hand-holding. And then we developed all on-demand webinars. So we have single lectures, but our best seller is our super bundle, which is basically everything you need from educational, clinical, didactic, to all the templates, the consents, everything that you need to get started, but you just don't have anybody hand-holding you through that process. So it's less expensive, but it gets you similar information, if not without the
So we're going to want the link for that so that we can put that in the show notes. So if anyone is listening and wants to know those 2 different programs and the fees,
they can just go to the hormonalhealthinstitute.com, or you can go to my consumer webpage, which is drhotflash.com. And there's a medical professionals page there you can click. I actually have it.
So suiting that you have this orange shawl on. I like you.
Thank you.
You have guts. I never had guts to do a book title that was that inflammatory, and I'm sorry that I didn't have those guts. You've got, you're on enough hormones.
Well, let's just say I've pissed off a lot of people. But unfortunately, the mission's too big and I don't really care.
So tell us a little bit, because we're coming close a little bit toward the end of the show here. What is going on with the FDA and so we just said women can go. So you said Save Our Hormones, or we'll repeat what those websites are. But in a nutshell, what's going on and the way that you like to talk about it and present it with the FDA?
Yes, so the FDA commissioned, quote unquote, an independent committee, which was completely bought and paid for, to basically evaluate the clinical utility of compounded hormones. And just to give people's perspective how big this is, if they were to eliminate compounding hormones, men would be just fine because they have tons of commercially available FDA-approved products, which they could use for their testosterone and erectile dysfunction. If we eliminate compounding for women, we will eliminate 100% of our testosterone prescriptions because there is zero FDA-approved testosterone products for women, and we will be, pardon my French, screwed because we will have zero options to treat our testosterone.
And you should be angry. You're listening to this and it's making your blood pressure go up a little bit. That's because you're an intelligent, sane human being. Yep. You've just understood the value of these hormones, and they want to actually take them away from us. This is important.
They have close to 100 products available to them. And when men get testosterone deficiency or erectile dysfunction, they get exactly the drugs we need. What we get are psych drugs. So they're eliminating
what drugs?
Psychotropic.
Oh, psychological. Okay, psychotropic. Because it's all in our head. It's not in our hormones.
So when they're trying to say that testosterone is all about libido, and it's not. So then they're also will eliminate our ability to get a lion's share of the compounded estrogen and progesterone products that are not made well, that are synthetic on the market. So
that Bijuve, right? Yeah. That is the thing that they're saying is the FDA approved. It's made by the same company that's the old CEOs of Premarin and Prempro. That's who made Bijuve. And
it would be okay. The thing, it's bioidentical, but what they're missing is that although they're good hormones and bioidentical, they're giving them us in a pill form, which processes through the liver and kicks out clotting factors. So whenever I'm giving hormones, it shouldn't go through the liver if you can avoid it.
Never
so
be
it
oral.
Didn't solve one of our problems. So unfortunately,
mostly never be oral.
So the FDA hired this commission, and mind you, and I worked with Big Pharma. I worked at Procter & Gamble for 10 years as their medical director, helped them launch a testosterone patch for women. And it's not that Big Pharma is bad, but it should be used appropriately. And when there are Big Pharma creating these monopolies that are trying to eliminating compounding because it's costing their profits billions of dollars that compounding is taking away from them, they want that. And FDA is funded over 60% by Big Pharma. So you can't tell me it's not a conflict of interest and that there's not a lot of folks that are paying and buying off committees. And we actually, a group of us, I testified to that committee. I was actually one of the reviewers of the final report, and it was complete crap. And it was so gender biased, I was just like, my head was blowing off. I was so angry. But what's happening is they're trying to say that this is independent and this is appropriate. And we submitted over 1,000 studies supporting bioidentical and compounded hormones. And they picked 13 that weren't ones that we studied, which only 8 were DHEA and the rest were other weird hormones. And they were small little studies, and they made their claim that they're not clinically utilized or properly utilized for 13 studies. It was ridiculous. So they came to the conclusion that compounded hormones were not necessary and that women didn't need them. And the United States, basically, medical population didn't need them.
And there's 8 million women on hormones today in the United States. Half are on bioidentical hormones. That means 4 million women would be affected. The other half are on different forms of hormones. Before the Women's Health Initiative, I don't know exactly the number, depends on the study you read, but there was something like anywhere from 10 to 20 million women on it. This was what women were given to be feminine forever. So This is a big deal.
It's a huge deal. And what's really interesting is that our coalition actually hired a really high-powered attorney to look into the conflict of interest, and they actually legally overstepped their bounds. And there's actually good documentation and data to support that this was not an independent study, that it was highly influenced by the FDA, and that they were pushing an agenda. And we caught them with their pants down. And unfortunately, the problem is a lot of folks, as we know, in medical journals are quoting that information now as it's the Godspell preacher template of 10 commandments, and it's not even true, and we've discredited it.
Last week in the New York Times, there was an opinion piece all on the FDA, and they explained that the culture of the FDA is to be very pro-industry. The more pro-industry you are, the higher up you get to retire with a bigger package, and then once you retire, you go work for that very industry that you've been policing. So it's conflict of interest on top of conflict of interest. You can't really have an independent FDA the way that it's set up, and the women are taking the brunt.
Yeah, and it's interesting. I wrote a 2-part article for the International Journal of Compounding Pharmacy, and it was called "I'm Hot as Hell and I'm Not Going to Take It Anymore: The Gender Bias in Menopause, Treatment of Menopausal Women." And it outlines all the gender bias that occurs in medicine against women, but in particular when it comes to hormonal health. And I'd be happy to send you the links to those articles.
Oh, I would like to see that. Would you do that? And
yes.
Is it true that when pellets came out within 6 months, it was insurance reimbursable for males, but it's never really been like that for women?
Early on in my career, we were treating men and women, and they were almost 100% covered by insurance and very rarely covered by insurance for women. And it was another example of the gender bias.
Why is that?
Because men are running the show. I mean, not that I love men. I'm very pro-male, but unfortunately you have a very male-dominated decision-making body that are making those rules and regulation, and they don't see the value. And unfortunately, organizations like the North American Menopause Society and ACOG and all these organizations keep putting out guidelines that keep slamming hormones for women.
I know.
You're supposed to be advocates for women, and yet you're our worst enemies. So
I was lecturing at a naturopathic conference. It was called the Women's Health Institute in Oregon, and it was all NAMS, North American Menopause Society. That's the acronym. They were saying if you don't have a uterus, you don't need progesterone. They didn't believe in estriol. Why your body's going to make some estriol out of estradiol? Why give it? Even though it upregulates again those sticky, critical adhesive proteins between enterocytes in the gut wall. It's just.
And a lot of those people on those committees and run those organizations are industry folks. So how can you tell me, again, they should be unbiased and under-sponsored by Big Pharma, and they
So
are.
what can the person that's listening, that's getting their blood pressure to go up, besides going to find someone to go on balanced hormones, what can they do?
They really need to talk to their representatives and kind of let them know that they understand that there's these movements to try to shut down compounding pharmacy, and that their senators and representatives should be supporting the use and utilization of hormones and compounds, but also to go to savemycompounds.org, and also the organization that you recommended,
WeTheWomen.com, right?
The women, and make your voices heard. Give the testimonials on the things that are doing, and the more and more people we get screaming that we need this, then maybe they'll listen.
And also buy Dr. DeRosa's book. So just tell your book again. Do you have a book there? Do you have a cover to hold up at all?
Unfortunately, I don't.
No, because she's not in the right house. Okay. But you got to say your title.
It's How Your Doctor is Slowly Killing You, a Women's Hormonal Health Survival Guide. And then I did a second edition, which we actually flipped it. It's the Women's Hormonal Health Survival Guide, How Your Doctor is Slowly Killing You, the second edition. So,
how come you changed the title from the first to the back in the second one?
We wanted to see the response to both. How was it? Kind of an experiment. Interestingly, it's about the same.
Rose by any other name.
I think whichever way you organized it, the How Your Doctor Was Slowly Killing You came out first, no matter how people thought of it.
Well, I have loved having you on the show because I would not be who I am today without being on bioidentical hormones. I really would not. And I don't want testosterone not to be available. I don't want oxytocin not to be available. I don't want Bi-Est, which is estradiol and estriol, not to be available. And, not only do we use this for peri-menopause, which is happening earlier and earlier. You heard our good guest talk about her going through peri-menopause in their 20s. We're seeing the hardwired biological milestones of reproduction occurring earlier and earlier because we have endocrine assaulting potentially chemicals in our air, food, and water. So this is a big deal. It's a very big deal that humanity is changing a bit, and we need to caretake our hormones, and we don't want to lose the right for the right medications to do that. So we all need to be in this together. We can't have enough physicians like yourself that take the time and the pain to write a book like this and to then go out and also train doctors. I'm going to want to really talk to you, and you're going to send me those links so I could put them in the show notes, and also the link to that site where women can go give their testimonial, and I'll add the other one. So this is going to be a great show note. You want to go to drlindseyberkson.com. When the show goes up, take a look at the show notes. I also have launched in the pandemic a membership because I normally lecture a lot, and of course all lectures were canceled. So I launched a membership which has a level for docs and pharmacists at the top, and then savvy patients in the middle. And then I love to wake up every morning with my cup of joe and sleuth the literature. And I post a lot of that, so you learn a lot. So there's these different levels. So if you're interested at all in having conversations like this to stay up on top of your health, your loved one's health, your patient's health, and to also know what to do to maintain your rights, you can go to drlindseyberkson.com/membership. And we have been lucky to have this physician on the show today and hear all of these clinical pearls. Well, it's a big one, just monitoring your FSH while you're on hormone replacement and of course, your sex hormone binding globulin. These are biggie pearls. They're beautiful jewelry, and I am a woman and my hormones keep me feminine, and I like to have my baubles on me. So those were pearls of information. I hope that we become friends. I've never met you before, and you're someone I would like to keep in touch with. So thank you so much for being on the show. And
I'll be at 8-4M, so maybe we'll see each other there.
Were you going to be in Vegas? You're going to be in Vegas? I'm going to be in Vegas, so maybe we can have a meal together. We could break gluten-free bread. That would be great. And let's really try and make that happen and not just say that, because I look forward to meeting you in person. You're doing great work. And I can't thank you enough for helping us fight the fight, because we have to do it. And there's so many fights to fight right now. Life is it gets so wearisome to know that people are always trying to take away more of your rights and want to take it at the same time give you a wallet biopsy, a walletectomy. And so we need community and we need conversations like this. So thank you so much for your time.
Thank you for having me. It's been awesome. I so look forward to meeting you in Vegas.
Okay, bye, everybody.
Bye.